Give everybody a couple more minutes to log on here before I kick us off. Seems like a lot of people waited till their their clocks hit 2 p.m. exactly. I totally understand. I do the same thing. I would have done it today, except for I've had so many Zoom issues. I didn't want to risk the fact that this room might not exist, which is the problem I've been having up until now. So I'm happy this link worked for everybody. I just wait a few more seconds.
Some early childhood folks, and I was like, I feel like we should be making people aware of this. It's probably gonna pass, but like
It'll easily.
um
Your elections.
I guess obviously it's something that we care about. That would be really great if it happens, but also
All right. I'm going to go ahead and get us started. For those of you who I haven't met, which I think is, I think I've met everybody here, at least casually. My name's Jim Pavlik. I'm the Senior Program and Policy Analyst at the Behavioral Health and Wellness Program. The Behavioral Health and Wellness Program has the STEP grant to provide technical assistance in the domain of cessation, which makes today's topic right in our wheelhouse. It couldn't get more in our wheelhouse. That said, what I have today is not like a formal presentation. These are not scripted notes. This is, I also want to remind everyone that I'm not the communications TA. I did my upbringing in public health, started off as a healthcare, or I'm sorry, a health education and communications specialist. But like framing arguments and trying to be super persuasive to the community is not sort of what I do now. And so these are what I think of when when somebody asks me the question, why should we do cessation programming? These are the things that I think of. These are and I put them in the order that I think they're the most important, where the last one I think is the most important reason. That said, your order may be different. The way that you want to, if you want to take any of this information back out to your community or to your other community leaders, then you might have to change the way you say it. So I encourage you to put them in your own words. And then after I present the notes that I have for us, I invite you to critique them. If you particularly like one, let me know. If you like the idea that I expressed but don't like the way that I said it, offer your own. I'm happy to hear other ways of talking about these things. And I left a blank slide in here so that if you have other reasons why we should be doing cessation that I don't list, I definitely want to hear from you. And then, of course, this learning community call will be is being recorded, and then it will be archived, and then we'll just sort of have a nice big long list of justifications for doing what we do. So with all that said, like I said, I do have some notes here, some things I want to share. These are my rationales for why we do what we do, if I can get this to cooperate. So the first one is we tend to think of our larger comprehensive tobacco control sort of regime as being a dichotomy between like prevention, which is something we do for kids, and cessation, which is something that we do for adults. And that's certainly a fine breakdown. It's a little simplistic. It's certainly far more nuanced than that. I would also include sort of our policy protections to be related but distinct from both prevention and cessation. And the three of those things all really work together, which is one way for me to say that even though I am going to be exclusively making the case for why we should do cessation, I'm not saying cessation instead of these other things. I'm not saying cessation more than these other things. We know, I mean, it's just an evidence-based standard at this point that the best tobacco control programs are comprehensive in nature, and which means that they have to do a little bit of all of these things. And if we were to take out any one of the pieces, we experience a greater loss in doing that to our program than what we save in effort or money. So I make the case for cessation, but even though this one is going to say that like no prevention effort is going to be perfect, no cessation effort is going to be perfect either, but why cessation? One of the reasons is because no prevention effort is going to be perfect. It's just that simple. And we know that because we have spent decades of time, monster amounts of resources in terms of labor and money to make sure that high school kids aren't doing cocaine and methamphetamine and drinking and participating in all sorts of risky behaviors. And yet all of those still persist. And that's not to say that prevention efforts aren't effective, right? It's just that they're not going to reach zero. And that's just the bottom line. And if somebody escapes that safety net of what prevention is having to offer, then we have to deal with the repercussions of that loss, right? That is every teenager that initiates tobacco use becomes dependent, is going to become a dependent adult, and we have to deal with that. And so why cessation? Because that's what that's what dealing with it means is we didn't help them enough when they were kids, and now we need to help them as they're adults. So that's, again, I put them in order from least important, I think, in my opinion, to most important, but this is a pretty important one. Historically, our prevention efforts have not hit 0% initiation and dependence. It's sort of a situation where we're in a no gainsaying the obvious situation, but there are a lot of current tobacco users, and a lot of them are in their late teens, 19, 20 years old. They're in their 20s, they're in their 30s, they're in their 40s. Right? And even more of them are in their 50s and 60s and 70s. And once you're getting into those late 30s, 40s, and 50s, that's where we're talking about people who are developing chronic diseases due to the habit that they started as teenagers. So we need to deal with the realities that we have, and we can't just say like, well, nah, I don't want to instead. And this is going to be tied in to the final bullet point on this slide, which, by the way, is my only slide. Right now, the estimates vary. The CDC gave us a figure of 480,000 deaths per year due to tobacco use, really just to cigarette smoking and not other forms of tobacco. A more recent analysis has something closer to 527,000. These are estimates. The range is about 500,000, right? That's 500,000 deaths every single year going back for at least almost 10 years. 2014 was the 480,000 figure. In the years preceding the 480,000 figure, it was 465,000. So this is roughly the figure that we've been dealing with for 20 or 30 years. That's a lot of people every year. And the thing is, if you have quit tobacco and you've been quit for 15 or 20 years, your risk of developing a chronic disease is the same as a never smoker. Which is to say that if we get people to quit in their 20s and in their 30s, or even in their early 40s, by the time that they would be developing chronic diseases and dying from them, it will be as if they never smoked, right? That's a big, big impact that we can have if we engage in cessation, right? That, again, that one maybe seems a little obvious, but I hope that why we should be doing cessation is also obvious, but there's been so many questions of it lately, I don't know that it is. This is a big one, right? I mean, I don't put this last by any means, but appeals to the financial cost of tobacco smoking seem to excite people, and it's not a small amount. It is, when I say billions of dollars are lost to premature morbidity or mortality. And this is in direct healthcare costs. When we just limit it down to direct healthcare costs, we're looking at on orders of magnitude about $150 to $200 billion a year nationally, right? And those are low end estimates of how much just the direct healthcare costs. But it's not just direct healthcare costs, it's also reduced productivity. People who smoke are more sick and they're more severely sick. They take off more time from work. Many of them end up losing their jobs due to the illnesses that they have. And we all pay for the consequences of both of these costs. And I didn't add a bullet for this just because the estimates for the range can get really dicey. You have to do a lot of economic modeling to figure it out. But whenever we spend money on something like somebody's heart disease and managing that heart disease for a much longer time because they developed it so much earlier, that's money that we couldn't spend in other areas. It's money we couldn't spend in education. It's money that we couldn't devote to the National Institutes of Health. It's money that we couldn't spend in investments, other kinds of investments. It's money that we couldn't spend in infrastructure. An article from Lancet, I believe it was in 2022, it could have been earlier this year, estimated that when you add up all these things, direct healthcare costs, loss of productivity, and loss of economic trajectory, the total amount we've lost is about $900 billion in 2020. $900 billion. And to put that into perspective, the entire budget of the Health and Human Services is $3 trillion, right? So the cost of just tobacco is 1/3 of the entire budget of all of Health and Human Services. Half of Health and Human Services budget goes to CMS, it goes to Medicare and Medicaid, right? So we're talking about, we could almost fully fund all of Medicare and Medicaid just with the dollars that we lost in 2020 due to tobacco. This is a gigantic figure. And it's also a figure we're all paying for this, right? In the sense that, you know, if that person who gets smokes and gets sick and then has to receive care, eventually dies too young and leaves the workforce, if that person's uninsured, we're paying for their healthcare through our Medicaid tax dollars. And if that person's insured, then their premiums go up. But it's not just their premiums, it's all of our premiums, it's all of our copays. And then, of course, when that money is redirected into something like this, we're paying for it because we're not getting the benefits of having invested that money in something that maybe we care more about or that more directly affects our lives. So that's another big one. Use the right mouse. I'm not a huge fan of this one, but you just can't avoid that it shows up all the time. And this showed up at the or the 835 conference, where somebody said, you know, should we even be spending so much money looking for harder and harder to reach smoking populations to try to get them to quit? Is it even worth it? And the answer is yeah. I'm not sure why this answer wasn't provided during the conference. I did rush out to try to find that gentleman who asked the question, but he had already vanished. It has been estimated fairly recently that for every dollar that is spent in a cessation program, we get about $1.26 back. So if you dabble in the markets, if you have a 401k or 403b, if you own personal stocks and you're looking at your return on investments, 26% return on your investment is actually pretty good, right? And I don't know what the return on investment is in prevention. If it was higher, if it's a 31 or 39% ROI, there could be an argument that we should just invest all of our money where there's a bigger return. But 26% is pretty big. And it's still ultimately a cost savings. And the reason why it's a cost saving is tied to the things that the 2 bullet points right above it. It is so very costly for us to have prevalence rates as high as we do. One argument I've heard fairly recently is that people push back against public health interfering in adult health behaviors because adults get to make a choice to live as they choose, and we shouldn't be interfering with that. And there's a couple things to say about that, but the first one is this: while an adult may has the freedom, say, to choose an unhealthy behavior, at least however you determine that should be mediated through a social contract. But let's just say we just make it a given that adults do in fact get to choose their healthy behaviors. We need to understand that they didn't choose it as an adult. 88% of individuals who currently use tobacco as adults began smoking or using tobacco before they were 18 years old. And 98% of them which is to say nearly all of them began before they were 26. And that era of 18, 19, 20, up to the 23, 24, 25, your brain is still developing. And I'm not suggesting that we should all agree that childhood extends until you're graduated from your undergraduate degree, you're 25 or 26 years old, but it is in fact the case that the brain is still developing while these addictions are being formed and not afterward. And there's a reason for that, right? It's really hard to actually develop an addiction after you're 26. It's not impossible, but it's very difficult. Which is all to say, we have a couple things going on here, which is number one, we're abandoning adults. If we're arguing we shouldn't do cessation for adults because they had the choice to do this and they had the choice to go away, if that's the argument, then what we're saying is, well, because they made that choice when they didn't have the ability to make that choice, we're no longer going to help them. So these arguments sort of run afoul one another. But the other thing I want to highlight here is that this is a dependence. And it's not a light dependence. If you've been with me at all through a lot of my more recent presentations, the justice-focused tobacco cessation one that I did, and a couple that I've done on e-cigs, I talk about dependence and the intensity of nicotine dependence quite a bit. It's been estimated that about 90% of regular tobacco users are addicted to it. Dependent, in the same way that you're dependent on other drugs, right? And so whether or not adults are even exercising their freedom to smoke is an open question. I would suggest that they aren't. And there's some evidence to support that. And the main evidence is this: 90% of current tobacco users, 90% of current tobacco users say they regret having started. 70% or so say they want to make a quit attempt in the next year. And yet 15 points of them, 15%, don't make a quit attempt. They wanted to at the beginning of the year, but the right opportunity never arose throughout the entire year, right? So so we have 90% regret having started, but only 70% want to make a quit attempt. Something's going on there. 70% say they want to make a quit attempt, but only 55 do. Something's going on there where choice isn't being exercised. And it actually gets worse than that, because about 55% of current smokers make a quit attempt every year. And 95% of them don't do it. They fail. They fail at their quit attempt. So they are exercising their right to choose not to smoke and then being unable to do it. It is in fact the case that the majority of adults, of adult tobacco users, are not exercising a choice at all. That's why cessation. That leads us to the last bullet point. When we're talking about dependence, we are talking about a mental health care issue. We're talking about a medical health care issue. Healthcare is a basic human right. And having access to treatment is a right. And if we don't build these cessation treatment options for them, then no one will. And having a right that you don't have any access to is not having a right at all. So that concludes my comments. So I look forward to yours. Anything I say like strike home? Did it make sense? Did you like them? Would you like me to say them differently? Would you say them differently if you were to take them out into your communities? Or I have this blank one if you want to just say something that I forgot. You will not hurt my feelings, I promise. I'm very tough.
I just popped on, but you're talking about it's a choice for an adults and doing this tobacco profile. I've heard that multiple times. They don't want these do it, but adults, we can choose it. So when you said that, it's like, oh, that's the theme here in our county.
Yeah, we hear it all the time, and I think the first time it really struck home to me is actually with adolescents, because a lot of adolescents are smoking. This is back. I've been in this long enough that I've been through for the transition from smoking to vaping in high schools. And what kids used to say is, well, I only smoke on the weekends. I only smoke 2 or 3 times a week. I just do it for fun. I can quit anytime I want. And so what we would just say back is, well, then prove it. Just how long do you normally smoke? They'll say, I'll smoke on the weekends. So you can't say like, just go 2 or 3 days, because they're used to going 2 or 3 days. Say, give me 2 weeks. Go 2 weeks without smoking at all. They go through 2 weekends and they've proven to me that they're not dependent. Most of them don't make it. Nobody's exercising a choice. That's just the way the brain works. It feels like a choice up until the minute you decide to quit and realize that you can't. Yeah, it's a tough one. Choice is a weird, and I know it's a especially loaded word for our more macho rural counties. And the thing is, if we're providing tobacco, so it's the policy conversation around choice is a little different. That's a lot harder to finagle that rhetoric, right? Because if you're limiting where you can't smoke in the parks, you can't smoke on the greenways, you can't smoke here and there and there. I can understand. I get where that comes from like a libertarian standpoint. We're like, yeah, you're saying I have the right to smoke, but I don't have the right to smoke anywhere. And so, yeah, I understand that rhetorical conflict. I think it's easily resolved, but I get it. But when all we're talking about is like building capacity to treat dependence for the people who seek help, like we're not infringing on anybody's freedoms. It's when they want the freedom to quit that we want them to have the freedom to access somebody that can help them. But thank you for commenting. What did I leave out? Did you guys have any comments of your own? Any if somebody were to ask you, like, why do you work in tobacco cessation? Why are you trying to build these systems? What would you say back that I didn't say? Or maybe you would say what I said. I don't know.
For me personally, this is something that I learned when I first started in this program. But it's who the big tobacco industry targets. And it's like with advertising and with the fact that they know the big tobacco industry knows that like addiction starts off early, and so they try to get purposely youth to purchase their products and become addicted. That way it's just a continuous cycle. But my whole point of this program, at least when I try to educate people and have them become aware of it, is at the end of the day, like I can't tell people what to do because that would just be hypocritical of me. So what I try to do is just give them all of the facts, give them all of the knowledge, and then from there they can make an informed decision, because I'm not going to tell somebody, oh, you should actually quit because you're inhaling X, Y, and Z, when they could give me the same argument of like, oh, okay, yeah, so if there are a bunch of forest fires and I breathe in that, that's just as harmful. Do you know what I mean? So it's like those little, like, I try to avoid those little conflicts or those little arguments, and I just say like, I don't care what you do. I said I would just say that my job is to give you all of the knowledge that I have, and to just tell you kind of the facts that I know in my scope of work, and then you can make your informed decision from there. That's pretty much like my motto with it.
Yeah, that's a great one. I would say though, well, I'll get to you in just a second, Melinda. This reminded me of the forest fire thing. Like, it is just as dangerous for them to breathe in the smoke from the forest fire. This is one of the things that we have to be aware of with the constant forest fire smoke that we're breathing in, because it just used to be the case that an occasional fire here and there, this region or that region, 2 or 3 days out of the summer, and you breathe in some solid particulate matter. If you're not particularly sensitive, you don't have asthma, you're not elderly, suffering from COPD already, you'll probably be fine. Your body will process that. But that's not what's happening with cigarettes. If you breathe that smoke in every single day, it would be just as bad as smoking. The problem with smoking is that you do it every single day. And as a matter of fact, with the fires that we had earlier this year, there were several newspaper articles where what they were trying to do was estimate how bad 3 days of that smoke was, and their unit of equivalence was how many packs of cigarettes a day did you smoke during those 3 days that you're inhaling those forest fires. The residue of combustion, the byproducts of combustion, are extremely bad for you. And so if somebody does give you that argument, just say yes. It is absolutely as bad. And if you breathe the forest fire in every single day, you would know it. And we do know that, by the way, and this is not like a laughing matter, because firemen, firefighters have greater incidence of lung cancer than the general population because they breathe in the byproducts of combustion all the time. Melinda, you might have to unmute yourself.
All right. Can you guys hear me?
Yeah.
Okay. So I definitely I agree with what Nikita had said. We're here to really educate. Unfortunately, we cannot force anybody to quit. And I also worked in a substance use program, so I understand that nicotine dependency is a form of a substance. So sometimes we also have to see that maybe there's other factors that make them use those substances, and it's not an excuse, but we as educators, we have to definitely include that as well, because if you tell somebody, hey, why don't you just quit this? But what are the fact? Why are they doing that? Sometimes we have to really see why are they doing that, and is there anything that we can maybe bring to the table to have a secondary option for them to quit. So that's kind of like my perspective on that, just because I've been in the substance use field, and I try to really go into their mind. Why are you doing this? And quitting smoking is hard. Quitting substances is hard, and it's not going to be an overnight thing. Some people, they're lucky they can quit when, like cold turkey, but for others, it means, okay, so what am I going to use now as a substance? Because this is the substance that made me feel good at the time, not looking at the health, from the health, but looking at it from the mental health perspective. But yeah, again, what Nikita said, we can educate on the what smoking and vaping does, but we can unfortunately not force anybody to quit.
Yeah. You definitely can't, and you shouldn't. I'll add a nuance to that, which is that we do work in space. BHWP does work in spaces where people are forced into quitting. We don't call those quit attempts, technically speaking, through our survey systems. But we do work in substance abuse, residential substance abuse treatment facilities, and we work in jails and prisons, other places where people just simply are not allowed to smoke, and they also live there. So they're confined to that reality for a while. And even in those spaces, we can get genuine cessation. Generally speaking, it's not the best strategy. It's not the one we want to go to. We want people to come to cessation on their own. That's what education, that's what raising awareness does. But we're not just educating on the harms of use, the benefits of quitting. We're also raising awareness of the available resources. And so there have to be resources that are available for us to raise awareness of. And go ahead.
It's kind of like the harm reduction concept, right? So harm reduction provides Narcan, harm reduction provides clean needles, they provide fentanyl testing strips, but at the same time, they're using that opportunity for individuals to get those resources out there in case they're ready to, quit the substances. So it's pretty much the same concept.
Yeah, it's very similar. The only difference to me really is that there's a real sense of urgency in, like, if you're doing a needle exchange site or a clean injection site or something, a safe injection site, sorry. If you're doing something like that, there's a real clear idea that, like, we have to let them live through today so they can change their mind tomorrow. And that sense of urgency isn't there with nicotine, because they don't die tomorrow. The chances of accidentally overdosing from nicotine, especially as an adult, is basically zero. It's not impossible, but it's very, very hard. But 50% of people who do use nicotine do eventually die from it, but it's 25 years, 30 years from now. And so, yeah, the harm reduction argument is, they're very, very similar. There's a little different. I would just say that, like, all the stuff you're talking about, like, when somebody's motivated to quit, and we have to explore with them, like, why they use, what benefits they're getting, and so we can replace those behaviors, developing new coping strategies. That's what a cessation intervention does. And that's why we have to build those resources, because educators can't necessarily do it, right? And moms and dads and uncles and shop owners can't do it. So we need to develop the capacity of our health and health adjacent centers to take on that, like, counseling and coaching burden. Yeah, I mean, the fact is that the majority of smokers, smokers in particular, but tobacco users more broadly, want to quit. But without help, they're going to try and fail and try and fail and try and fail and eventually succeed. But I'd rather them succeed today than 7 years from now.
It's funny because my mom, so I was born and raised in Germany, and Germany, the culture, a lot of people smoke. My mom was smoking until she had my brother, and that was 25 years ago. So whenever she had him, she quit. But recently, about I think 2, 3 months ago, she started smoking again. So that also shows that even if you're a long time, refraining from those kind of substances, there's always a chance that you relapse into it.
Yeah, for sure. I mean, it's your brain knows, and your brain doesn't. The whole idea of, I mean, we can talk all day about different models of addiction, but some of the things that we do know is that one of the things that addiction does is it changes what your brain thinks is important enough to remember, and so it holds on to the memory of what nicotine does to it, which it views as positive, perhaps for your entire life. It will reduce the receptors, it will reduce some of these other things, but it will retain the memory of what it does to that dopamine reward pathway, and remind you occasionally, like, if you wanted to feel better, you could do that. It's insidious. And that's true of all addictions. It's not just nicotine. And I also know how hard it is to convince adults, by the way, that what they have is an addiction. My mom despite how long I've been in this career, my mom insists on smoking, which is horrible. And she's already had an uncle and a close friend, I'm sorry, one of my uncles, one of her brothers, die from COPD. And her mom struggled with diabetes. Her dad was a smoker. So it's the whole group of them down there that just insist. And it took my mom until she was in her 50s before she finally acknowledged that she was just simply addicted, that she definitely wasn't choosing it. She had never really tried to quit before, and she had a health scare when she was 50. She tried to quit. She tried to quit a couple times. One time she made it for like 6 or 7 months. She relapsed and she hasn't tried again. So now she's one of those 90% that regrets having started, but doesn't have any interest in making a quit attempt. But it's also tied to her identity. Like I can't get her to even quit to a less harmful form of tobacco. I can't get her to switch to e-cigs. I can't get her to try the nicotine replacement therapy, even like just adopting that as like a lifestyle. And she's just not interested. To her, like being a smoker is a core part of how she walks on Earth. Other comments, other arguments for why we do cessation. If somebody were to challenge you on the street, why are you wasting your time doing this? That's my Southern Indiana accent. I'm not making fun of anybody there. That's the accent I grew up with. Okay. Well, I'm not going to hold you. I said what I came to say. I appreciate the conversation that we had. I had planned, and I still plan on doing the 5As in December. So the idea of the 5As, for those of you who that's still a new word and you haven't gone through a training, I highly encourage you to do it. If you are in charge of staff who are fairly new, I definitely think that they should do it. The 5As that's an evidence-based protocol for treating tobacco dependence. It was created for physicians for use in a physician's facility during the course of a normal clinical visit, but that was developed in the late 80s and early 90s for that purpose. But it has since grown to be applied to all sorts of chronic disease treatment and management, and in a lot of different sites. So we do it in dental offices, we do it in community behavioral health, we do it basically anywhere. If you're familiar with SBIRT, it is essentially the same as SBIRT, screening, brief intervention, and referral to treatment. There are very tiny differences. The reason I train in it is because it's a good thing that public health can do. They can volunteer themselves to go into spaces and teach those professionals how to do the 5As in their offices, in their clinics, in their workflows. So if you don't know how to do that, then go through the training that I'm going to be doing in December as part of instead of this learning community call. So it'll be an official webinar. The way I'm going to do it is I'm going to act like you are the professionals I'm training to do the 5As. And then after I'm done with that, so I'm going to limit my comments to about 30 minutes or so, which is the maximum amount of time you would normally have. And that would really be pushing the boundaries, but that's about the maximum amount of time you would normally have. And then for the remainder, I'll provide some notes on how I would adjust that training for different professionals or given different sort of time or space constraints. The slide deck that you see at the beginning of the presentation is one that will be available to you to use. You can just take it with you. You don't have to do any adjustments to it, but I will make some recommendations of how you can adjust it depending on who you're talking to and where you're talking to them at. And that'll be the whole thing. And I'm bringing that up not just so that you can be aware, and when you see that invitation, know that that's what we'll be doing, but also to say that I decided to do that because when I was doing all these meetings with everybody earlier this cycle, there are a ton of new people. And so I know that there are people who've never gone through the 5A's trainings before because I am the one who normally does it, and I haven't done it in a few years. So I saw that as a need. I think that it's important for you guys to know what that is and how to talk about it. Even if you never train anybody how to do it, you should know those words and what it's meant when somebody says them. But this is also another way for me to invite you to send me your requests for things that you'd rather me talk about. That's something I picked because I think it's a need, but if I'm wrong and you want to hear something else, let's do that. So I already have some requests to do an update on what's known about electronic nicotine delivery systems, aka ENDS, aka e-cigarettes, etc., Juul, other pod mods. So that's on the docket. I just put together an updated presentation on just that topic for Nebraska. I updated it again for Missouri, so I know it's a hot topic nationally. So I can just do that one out of the box. I already have it ready to go. I just want to adjust some data to get some Colorado information in there, which I also happen to have handy because I am also going through a TFCA process in a way, just like you guys are. So look for that maybe in either, I'm thinking probably maybe November. I'll just pop in and do a webinar. I'll make it public and then you guys can attend it. And then, but if you have other areas of interest, other things you need to know about, other things you're just curious about, I can always throw them into a learning community call, or if it's something that I think is worthy of a longer talk, I can always do it as a more formal scripted webinar. And you don't have to do it now, but just know that that's how responsive and very cool I am. So Michelle, thank you for your email. Look for that update on maybe November something, early November. And if there are no other questions, I guess I should check in. Does everybody feel comfortable with the TFCA? You guys have any questions that I can answer or directions I can point fingers and say like, no, go talk to somebody else instead? Okay, seeing a few thumbs up. I'll let you all go. Thank you all so very much.
Thank you.
Bye.